Good afternoon, everybody. So I think we'll make a start because I think people will join us as they finish their mornings. So welcome to this PLI event. You get two for the price of one today, a bit of dementia and end-of-life care. I'm Sarah, Dr. Jones from Norwood Medical Centre, and the reason I'm up here is I'm also the clinical lead for the dementia strategy in Sheffield. So a bit of quick housekeeping. Loos are in here. I think ladies that way, blokes that way. There's also loos outside. We're not planning any fire alarms, so if the fire alarm goes off, we need to leave. There's a fire exit to my right, your left, and there's obviously the way we all came in. So, and then lastly, I have been asked to encourage you all, after previous very poor feedback from PLIs, please scan the QRS code at the end of the event and give some feedback. It does help PCS to plan their future events. It also helps us to know if we're talking about the right stuff. Okay. Oh, it's not going to work now. It's not going to work now, Nat. So we're talking about dementia to start with the first half of the afternoon. Oh, it's done it. Well done. Oh, I think Natalie might have done it. And then in the second half of the afternoon, we're going to do end-of-life care. So dementia, we're going to divide up into sort of three bits. So the first bit, I'm going to talk to you about the diagnosis pathway. The second bit, which is the most important bit and the big bit, I've got all of my lovely colleagues over to the right who represent various organisations we have in Sheffield that are supporting our patients who are living with dementia and their carers, importantly. And then the last bit that I'm doing is a bit around crisis in dementia leading into end-of-life care, which will naturally follow on to our end-of-life care talk in the second half of the afternoon. I know I can speak for Anne as well from the end-of-life team. You know, we'd be happy to take questions. If we can fit them in as part of the presentations and talks, then we will do. But otherwise, if it gets a bit too crammed and busy, we'll all be around at break time for you to catch up with us then. Okay, so that's our agenda. That's the housekeeping, and now we can get on with it. Okay, so thank you. Next slide. Thanks, Nat. And next one again. So, I remember being asked by a colleague not very long ago, why would we bother diagnosing dementia? And I think I've been doing job long enough, as many of you here may be similar to me, that we probably didn't think we should bother diagnosing dementia in years gone by. And the reason we didn't really think we could bother diagnosing dementia is because we couldn't do very much about it. And us GPs in general really hate anything that we can't actually do anything about, so we'd rather just sort of ignore it and let things carry on because we can't fix it. And really, not so much has changed about that because we still can't fix dementia, although as you know, as we'll come on to, there are some new things coming along. But what has changed is our understanding that not diagnosing dementia for people can cause a lot of harm. By diagnosing dementia, you can relieve a lot of stress. You can relieve stress for the person who's experiencing the symptoms. You can certainly relieve stress for the person who's looking after that person, so the carers involved in the looking after your patient. You can give that person the opportunity to be involved in a discussion around what's going on for them and what they would like to happen for them. You know, that's really important. We all know the value of advanced care planning for people, and it couldn't be more important in dementia to identify the illness early enough that that person gets the choice to be involved in thinking about what they would like to happen. It means you can put support in place to try and avert crises. You know, so many of us see presentations during crisis, which can be incredibly difficult, very difficult for us to manage as GPs and healthcare practitioners, and awful for the patient, and often will end up in a patient ending up in hospital, which is actually the last place that they need to be and the last place that's going to help them move forward. So it is important. And then lastly, of course, there is the treatments of coming along for dementia. So at the moment, we're all very well used to the Aricept and similar drugs available for Alzheimer's dementia. But, you know, the truth of the matter is that they still have very minimal benefits for people. You do anecdotally get some people who clearly do improve with them. My experience is not very much, But nevertheless, as a GP, as being able to do something for someone, it is nice to be able to offer that treatment. So if you make a diagnosis at an early stage, you can offer a treatment intervention. Obviously, as time goes by, and lecanemab, donanemab that have come out this year, which haven't got the nice go-ahead to be rolled out in general, but they are very exciting, and they do the future for Alzheimer's treatment is definitely going to follow this pathway. And that is going to mean that we absolutely are going to have to identify people at a much earlier stage of illness. And we'll touch a little bit on that in terms of what that's going to look like. Okay, so next slide, please. So this is, just to illustrate the different sorts of dementia. So I'm not going to, teach my granny to suck eggs. Dementia is an umbrella term which covers a load of different diseases. The most common dementia in the UK is Alzheimer's dementia. The next most common is a mixed dementia, which is usually Alzheimer's and vascular. We then have vascular dementia, frontotemporal dementia, alcohol-related dementia, Parkinson's-related dementia, Lewy body dementia. So there is a wide spectrum of diseases which fall under the dementia umbrella. When a patient goes to a secondary care memory clinic, they will try and identify what sort of dementia they have, because it can actually make a difference in terms of managing their symptoms, or at least understanding their symptoms. And it will be very important going forward, because as they come along with these new treatments that are specifically for the Alzheimer's disease process, we're going to have to be able to identify which patients are eligible to actually have the treatments that will treat Alzheimer's dementia. Let's see. There we go. So this is a QR code which accesses the diagnosis pathway, which has been updated by the Dementia Strategy, of which I'm part of. It's on the press portal, so it's readily accessible for everyone. It includes the stuff around specific groups of people, particularly perhaps the learning disability group of people, and accessing a diagnosis. So if you go on to the next slide, I got it, haven't I? There we go. So the interesting thing in Sheffield, which isn't true of everywhere else, is the division of age group in Sheffield. So in Sheffield, we have it that the over 65s go to the Sheffield Memory Service and the under 65s go to neurology. The reason that is because the differential diagnosis in the under 65s is much, much broader. And neurology have the remit to look at a much broader spectrum of investigations. And they will probably be the service which will be initiating the new treatments for Alzheimer's as they come along. Because at the moment, the screening process to identify people that are eligible for that means that people either have to have had a CSF taken or a PET scan. And as most of you all know, PET scans are very difficult to access, particularly in Sheffield. But so under 65s go through to neurology. They have a very long waiting list. And the over 65s go to Sheffield Memory Service, and they have a very long waiting list. So current waiting times for both services are around about a year from the point of referral to the point of diagnosis. There are lots of reasons behind that. It was nowhere near that bad before COVID came along. COVID came along, and like lots of other services, it was paused, and referrals, referrals probably did carry on coming, but much fewer. But the service actually paused its operation. And then following COVID, then they had massive staff shortages and issues around that, and retention of staff. And so now we're in the pickle we're in, and we are working very hard in the background to try and unravel and deal with that and look at options of how we can improve that. So just to be aware for everybody here, there is a lot of work going on in the background, working alongside myself and the secondary care colleagues in both the memory service and the old age mental health team, to try and come up with different options of how we can improve the service. So the learning disability team, so basically patients who are already under CLDT and developed cognitive issues, it's quite straightforward getting them assessed for dementia, because CLDT will do the neuropsych testing, and they will basically propose a diagnosis of dementia, and then that's shared actually with neurology, because CLDT, in the wonders of the system that we work in, can't you get a scan. So if the patient needs a scan, that has to go through neurology. But we have created a little MDT pathway in that to speed that up so that patients within the CLDT system can get a diagnosis of dementia a bit faster. I still think we have an issue with patients who I suspect that we all have, who have a learning disability who are not under the community learning disability team. And so one of the strategy plans going forward is that we look hard at that group of people and make sure that we're making enough diagnoses in that group of people. There are other health inequality issues that the strategy is looking at, and that's particularly around ethnic minority groups and how underrepresented they are in the data that we have on dementia for Sheffield and across the board, actually. And so one of the strategy things going forward is that we're looking quite hard at it. How are we working with some of our community groups within ethnic minorities to try and improve presentation of people, how willing people are to present with their symptoms, and if we're using the appropriate tools to assess those people to make more accurate diagnoses. So one of the things that's mentioned on the pathway, and I want to just talk a little bit about, is pragmatic diagnosis of dementia. Those of you who know me will be bored silly of listening to me rambling on about this, but basically what it comes down to is the fact that we often see people who present to us in general practice at a late stage of their journey. The family are already telling us the patient's been deteriorating for years, they're cognitively really struggling. They're often presenting to us at a late stage of their journey when their needs are quite large. My feeling is there is no place for those people to be sitting on a memory clinic waiting list. We'd be far better off in those people to make what I've called a pragmatic diagnosis of dementia. And yes, I'm not typing it when I'm making that diagnosis, I'm calling it a dementia syndrome. But what I'm recognising is for those people, the most important thing at that moment in time is that they have access to services that they need. So they have access to the Dementia Advice Service, the Alzheimer's Society, the carer support services. We make that happen as quickly as possible, because actually referring them for them to sit on a waiting list to be too late in the journey to start on a treatment, I don't see the point. I don't think it's helpful, and all it's doing is prolonging that waiting list for the people that we'd really rather that did get seen. So I am very keen on people, us as GPs, taking that action of, if someone is presenting late in their journey, by all means we should be doing some screening and making sure we're not missing something else, which we would do anyway if we were referring on to memory clinic. We would be doing some bloods and we would be requesting a CT scan of their head. But beyond that, just thinking, are we best off in this case? This person is not going to benefit from sitting on a waiting list. Let's just make a diagnosis of dementia. We also have, certainly at my place, and I think I was just talking to Pete down there as well, about the fact that we've got patients who don't want to go. They don't want to go to clinic. They don't want to go to the memory service. Our practice is a few hundred yards up the road from the Northern General. Do they want to go? No, they still don't want to go. So at the end of the day, it's important to do what's right for the patient. We do have access through the old age mental health team for patients who can't get, for whatever reason, to a memory service clinic appointment. We can access help through the old age mental health team for a home visit assessment. But again, I think there is plenty of place for making a pragmatic decision about a diagnosis in some of these patients as well. And being able to, again, put all the things in place that we need to, talk to them about a diagnosis of dementia, talk to them about the help and support that they might need. If at the end of the day the patient's refusing to go, we've got one at the moment who, has been refusing to go for an assessment. He was refusing to engage with the fact that he might have a diagnosis of dementia. So we've done a capacity assessment. We've decided on what the best course of action is. We've sought some help and support from one of our colleagues in the old age mental health team. We've got on and made a diagnosis, and we've put support in place for him. and you know, at the end of the day, that's been in his best interest, and you know, definitely will improve his care going forward. So after a diagnosis of dementia, so in this, you know, this is whether it happens out in the hospital or it happens with us in the community, it's important that people are getting support that they need. So at the moment, if people are on the waiting list for the memory clinic, they will be given information and details about the dementia advice service that Age UK run. And again, that would be reiterated. And so when I'm doing a diagnosis in the community, you know, we're sort of making sure that people have information about all of the sources I've put up here on the list. We at Norwood, we use our excellent social prescribing team to do lots of navigating and networking for us and supporting patients into the right service that they may need. We've also trialled running a dementia clinic in the community, where we sort of went and did clinics actually in one of the dementia cafes. We've ended up, interestingly enough, bringing it back to practice just from technical issues of sort of not having enough privacy or enough quiet to have conversations with people. But it was an interesting exercise in just sort of engaging people with community services that are out there. Because one of the things we all know is trying to just get people to use the services that are there can really help them, but people are often reluctant to go. But I think the use of our social prescribing team can really help that and compliance with some support. So we are, as part of the work we've been doing over the last few years, we're encouraging our secondary care colleagues to help out a bit more too. So where patients can be made have a diagnosis while they're in hospital for whatever reason of dementia, we are asking our secondary care colleagues if they can do that. If they can't, and there may be good reasons why they can't, and the reasons usually are that the patient may be unwell with a delirium while they're in hospital. So if they are unwell with a delirium, but it's sort of likely that they've got a dementia, we're asking our colleagues in hospital to at least do the baseline stuff for us, at least make sure they've had a scan, at least give us the wherewithal to move things forward when that patient comes home. And then at our place, we'd probably choose to review them and decide if there is a place for a referral or whether we can get on with it ourselves. So new things coming up. So I don't know who here other than us is involved with the CogniSpeak pilot. So CogniSpeak is a neurology thing. It's a virtual reality, so it's an avatar on a computer which basically interviews patients. It's very jolly. I was involved right at the beginning with Dan with the project, and basically it interviews the patient and it monitors their responses, including their physical responses like their eye movements and their head movements, as well as verbally what they actually say. And it's been shown to actually identify mild cognitive impairment and dementia, and also identify the patients who are actually presenting with anxiety and depression, which is the highest proportion of people that don't have dementia that go to the neurology clinic. So the turnaround rate of diagnosis for a positive diagnosis of dementia in memory clinic is 10 times higher than that within the neurology setting. They have vast numbers of, I'm going to call it in inverted commas, worried well people who go to neurology clinic with cognitive issues. And this is partly where this study was brought out from. But now the CogniSpeak is being piloted in lots of surgeries, including ours. And the idea eventually, I think, will be that this will be a model where we use it as a screening process for people, and we'll hope to identify people at a much earlier stage of their journey and mean that they're going to be able to access those treatments that may be appropriate for managing Alzheimer's disease. As I mentioned before, the MABs, lecanemab, donanemab, there are studies going on in the UK. Dan is involved, joined up with the one that's going on in Manchester at the moment. And we have actually, I think, had 50 patients have CSF testing in Sheffield now to see if they're eligible for donanemab. So it's moving forward. And I think in our working careers over the next 5 to 10 years, we're going to see that as a new treatment available. I'm going to briefly mention we're also doing a mini cases pilot, and this is one of the things we're looking at to try and help with the waiting times that we have for the Sheffield Memory Service. So we're going to do a mini cases pilot whereby myself and a couple of colleagues will look at some of the referrals coming through, So don't shout at us too loudly if we come back to you and say, oh, we think you might be able to just make a diagnosis here. So, along with the cases model for everything else, it's just a supportive thing. We're just trying to perhaps aid in the process of referring, to improve the process of referring, to try and suggest people that don't need to be there, and perhaps even be able to suggest services that could help out with whatever the symptoms are the patient's presenting with. Right, I think that is it for me. And now I'm going to hand over to all my lovely colleagues. And first up is Elsie, who's going to come and talk to us from Age UK, who provides the Dementia Advice Service in Sheffield.